Okay, so just for everyone's background, I'm sure a lot of you are pretty familiar with the Tennessee Justice Center. So we're an organization that is a nonprofit public interest law firm, and we use individual cases to identify systemic risks to the state's safety programs and then advocate for change through legislative action, class action litigation, and client representation at administrative hearings. So today we're going to be specifically talking about the pre-admission evaluation, or PAE, as part of the choices application. I know this is a really big part of the choices application, and just for background and reminder to folks, the choices is a 10-care program that provides long-term services and supports to enrollees. Maybe many of you have been in our previous webinars where we kind of talk about the medical portion and the financial portion of the applications. And our organization helps kind of navigate and inform folks about the choices process. So today we're speaking specifically about the PAE. And today, the person who's going to be our main presenter is from our partners over at Elder Law of East Tennessee. And this firm is a law and estate planning firm that helps families respond with confidence to the challenges of aging and long-term care. They help protect what matters most to clients: quality of life for loved ones, cherished relationships, family wealth, and peace of mind. So our presenter today is Jill Schaffner, and she is an elder care coordinator over at Elder Law of East Tennessee. And she helps clients gain access to the care that they need and works closely with other service providers, like our organization, to coordinate the care. Jill has over 14 years of experience as a social worker in East Tennessee, and she's especially familiar with the 10-Care Choices program, having worked as a care coordinator for one of the program's managed care organizations. And she worked in that position from 2010 to 2014. So she has a lot of experience and knowledge about the PAE and the choices application process. And she continues to serve elder adults in her position now, people with disabilities and their families through her work at Elder Law of East Tennessee. So I'm going to turn my video off. And I should probably mention I'm Vanessa Zapata, and I'm a staff attorney at the Tennessee Justice Center. So folks, clients will work with me if they have some issues, and if anyone wants to kind of work with us on an individual basis for a case, please feel free to give us a call. I'm going to provide our number at the end as well. All right, I'm going to turn my video off and hand it over to Jill. Thank you so much.
Thank you, Vanessa. Can you hear me okay?
We can hear you. We can't see you.
Yes, that's by design.
Okay, just making sure.
Sure, thank you. So Choices is a long-term care insurance through TennCare. And to get Choices, you have to be medically and financially approved. You can think of that as two separate applications. So you have to have one of them to get the other. So today we're going to be talking about the medical application process of getting approved for Choices. So TennCare decides if a person is medically eligible for TennCare based on a PAE. PAEs are completed by qualified assessors that complete annual trainings, and most assessors are nurses or licensed social workers. These assessors meet with individuals to complete the PAEs, and then they turn that paperwork into TennCare's long-term services and support department, who review the documents, and then they make sure the paperwork is done correctly. They ultimately make the decision of what a person scores on the PAE. And assessors are people, and they're subject to human flaw. So when those nurses at TennCare get those PAEs, they may actually reduce the number of points that an assessor has put on the PAE if there's not documentation to support it. So you have to get a 9 on the PAE to get approved for choices group 1 and group 2. For choices group 3, you only need to show a deficit in one functional measure, and it provides up to $15,000 worth of care per year. But as of 2015, choices group 3 is only open to people who draw SSI. The PAE is the state's attempt to streamline choices medical eligibility, but the truth is that it isn't black or white, and the outcome of the PAE can be affected by the assessor and how a person responds to the questions on the PAE. Next slide, please. So we're going to go over this today to be sure that all the information is communicated to the assessor. You do not do extra cleaning or prepare for the assessor. You want them to see how things are in reality. You go through the kinds of questions that are assessed on the PAE to prepare for them and how intimate the questions are. Make notes beforehand of things that you want to make sure to tell the assessor. Don't depend on the assessor to ask all the right questions. Assessors have options of whether or not to do an applicant and collateral interviews. Those forms used to be required to complete and submit with the PAE, but they're no longer required if the assessor believes that there will be enough medical records. However, if you're worried about getting a 9, you may want to ask for the interviews. It's always better to have more information than less, I think. So try to get a doctor or medical professional to write a letter explaining the client's need for service. That may be particularly useful if the client is at home with some rehab care, to have a rehab professional write a letter saying the client's needed care costs more than $15,000. Next slide, please. So what is on the PAE? Next slide, please. The PAE measures functional abilities. So things that are assessed on the PAE are different than ADLs. Notice that bathing and dressing are not on this list of functional measures. Any deficits counted have to be backed up by medical records. So I strongly encourage my clients to start making a log of any kind of deficit, especially things like falls, hospitalizations with dates and what happened in the situation. So the reason for the deficit also has to be cognitive or physical disability. Any issues completing the functional measures that stem from mental health issues are like not eating because of depression don't count for the PAE. Next slide, please. So needing some of these skilled services could also get you some points on the PAE. And one thing I'll mention is that sometimes these points can be given in the short run, but if someone has something like a stroke, they may over time become more able and not need these skilled services, so that might get shifted later. Next slide, please. So how is the PAE scored? Next slide. So each functional measure has a possibility of 4 answers. The definition of each of these answers are different between the Medicaid rules and the PAE assessment. So I use the way the questions are phrased on the PAE questionnaire to argue that clients who need help at least once a day should be scored as a never, because that's at least 7 days a week. But you can see in the way that the Medicaid rules are written, it doesn't allow for that kind of interpretation. just another example of how PAEs are not black and white. And it's also important to note that behavioral functional measure is scored the opposite. So if someone has behaviors, the answer to the question would be always. And for the other functional measures, you can see that always is, they're always able to complete the functional measure, but for behavior, that would be different. Next slide, please. So here is the acuity scale for how many points you can get for having certain deficits in functional measures. So you can see that some of these are grouped together. So transfer and mobility are grouped together as one category. You can only get the highest value of the two measures together. So if a person always needs, if a person is never able to transfer, that would get them 4 points. But if they're also never able to ambulate, that they would score 3 points, but they get the 4 points, not 7. And that's true for all the other groups of categories as well. Next slide, please. So this acuity scale is for the skilled services that were in the previous functional measures slide. So you can see that you can get some points if you need tracheal suctioning, a ventilator, wound care, and so on. But see here at the bottom, teaching catheter ostomy care, teaching self-injection, those get no points. So the maximum possible skilled services acuity score is 5. So the next slide, please. So what are the functional measures assessing? Next slide. So they're measuring transfer and mobility. So transfer only considers your ability to transfer from the bed, chair, or toilet. Do you need help to do this? And is it from another person? So be sure to say if you cannot do it safely, if you fall back down. Falling back down is not specifically mentioned in the PAE, but could demonstrate your inability to complete the task independently. Mobility is specifically looking at your ability to be mobile in home. If you need help outside the home, you may want to report it, but often it doesn't get you any points. It's looking for if you need help from another person. Next slide, please. Eating functional measure does not include issues a person may have with meal preparation. This is really just looking at, can someone take food from a plate and put it into their mouths? It looks at physical assistance from another person. Does someone need to put food in a person's mouth? Does someone need tube feeding to be set up? One-on-one observation can count, as well as the person at risk for aspirating, or do they try and hide their food? Do they need verbal assistance or persistent reminders and encouragement to keep eating, or you need to eat all your food, or take a few more bites? General supervision of a dining hall is not enough to score for this functional measure, but if the client needs consistent supervision from the dining room staff, it may be helpful to get a written statement saying so. Next slide, please. Toileting looks at your ability to pull down your pants, clean yourself, and pull your pants back up. Incontinence care similarly assesses if a person needs help adjusting clothing, cleaning, and readjusting clothing after an incontinence episode. So be sure to mention if when you have a bowel movement, you clean yourself, the best you can, but afterward you notice that your underwear is messy. This can demonstrate that you cannot clean yourself properly. Maybe get a caregiver to write this in a statement. These are the kinds of things that aren't in medical records, but show that a person is not able to toilet independently. Next slide, please. So orientation. So if a person fails to remember their own name or recognize immediate relatives, that can show a deficit. If they don't know their address, that doesn't count, but assessing whether they know that they're in a nursing home or if they think they're in Oklahoma, something like that can count. And do they know what situation they're in? Can they make a decision that would prevent risk of harm? So I might ask, what would you do if there was a fire? Do you know who to call in an emergency? What 3-digit phone number can you call if there is a fire? So I've had people who answer this question by saying, I would call my son or daughter. Well, that doesn't get them the help that they would need for a fire. Next slide, please. Sorry. So for communication, there are two types. There's expressive and receptive. And so for the expressive, does the client say if they're hungry or thirsty or if they're in pain? So if a person has a UTI, for example, are they able to say to you, I'm having pain when I use the bathroom? And if not, that can count as a deficit. For receptive communication, they should be able to understand and follow simple instructions. Nothing complicated, like obviously applying for choices is not an instruction where noncompliance demonstrates a person's lack of receptive communication, but instead can they follow something simple like raise your right hand or touch your nose, or can you point to the television? Next slide, please. Self-administration of medication. This functional measure looks at whether a person has a cognitive or physical disability that makes it impossible to take medication independently. Pills and tablets, if they're given those, can they put those in their mouths? If they're dropping pills or losing them or not knowing if it's taken is a persistent issue that can be used to demonstrate that the client cannot do this independently. And you can get a written letter from a caregiver stating this. So always remember to report eye drops and topicals like creams or pain patches or injections. Not being able to do sliding scale insulin is not counted in this functional measure. It's counted in skilled services, which is kind of a shame because if it were counted with this functional measure, it could get a person 2 points. But in skilled service, it only gets a person 1 point. These medications have to be doctor prescribed or recommended. So over-the-counter medications still count, but you have to have the documentation that shows that the doctor recommended it. Refusal of medication does not count. Limited assistance does not count. TennCare defines limited assistance as reminding, encouragement, reading labels, opening bottles, handing to the applicant, reassurance of correct dose, and use of assistive devices, including a pill box. Occasional lapse in adherence to med schedule also does not count. The issue has to be persistent and caused by a physical or cognitive impairment. I will add that when I was doing PAEs, initially there was some confusion about, well, sure, they can put the medication in their mouth, but they don't know what they're taking. But that would be scored under orientation. Next slide, please. So behaviors like getting lost, wandering, aggression, disrobing in front of strangers, inappropriately, eating non-edible things, all can be counted as behavior. If a client has a history of wandering away and they have only successfully done this twice in 2 months, they still always need help with behavior because they need to be supervised at all times. Next slide, please. So we're going to go through an example. Next slide. We're going to use Ariel and King Triton. Ariel is our caregiver here for her father, King Triton. So she's attempting to get long-term care services for King Triton, and he has difficulties with several activities of daily living. He swims with a walker most of the time, but about twice a week, someone has to hold him under his arm while he's swimming to give him balance. At the end of the day, to go to bed, King Triton is too weak to get into bed by himself and needs Ariel to help him lift his fins into the bed. He also needs help getting into the tub, so Ariel has to help him get into the shower. Once in the shower, he has to get help to wash his back. King Triton is able to toilet independently, but about 4 times a week during the night, he has a bladder accident, and Ariel helps him by cleaning his PJs and bed sheets. She can't do this every morning because she has 2 small children that she also takes care of. So sometimes King Triton stays in his soiled pajamas until someone can help him change. King Triton has medications that he takes every day. He can take them all independently except his eye drops, which he is supposed to put in twice a day, but cannot do so by himself. So the first step is what counts in this example. So just see. All right, so we have mobility because he needs help about twice a week for someone to hold him under his arm. So that one counts. Transfer to bed. That one also counts because Ariel is helping him put his legs up into the bed. Or his fins, I'm sorry. What about the transfer to the tub? That doesn't count because that's not something that's listed on the PAE. Washing the back, that also doesn't count because bathing is not listed on the PAE. The incontinence care counts. And dressing does not count. And then there's the medication issue where he needs help putting in his eye drops. So now let's take a look at, next slide, please. Let's take a look at how this is scored. So for transfer, he's never independent. Mobility, he's usually independent. Toileting, always independent. Incontinence care is usually not. And medication administration is never independent. So based on the definitions, these are the functional measures as we've identified them. So the next slide, please. So if you take a look at the acuity scale to score, that's step 3, what's the score going to be? So for transfer, because he's never independent with that one, he gets a 4. For mobility, he scores a 1. For toileting, he gets 0, but for incontinence care, he gets 2 because he's usually not able to do that. And medication administration, he gets a 2 for that. So the score here is an 8 because if you add all these points, it looks like it's 9, but because mobility is grouped with transfer and he never can transfer, he doesn't get the point for mobility because he gets the maximum points because of his inability to transfer. So you need a 9 on the PAE and he scores an 8. So what do? We ask for a safety determination request form. Next slide, please. So a safety determination request form is a form that kind of supplements the PAE, and it's used to show why a client needs exceed the services provided in Choices Group 3. As of July the 1st, 2015, Choices Group 3 is only open for people who have SSI. King Triton's PAE got approved for Choices Group 3, but he doesn't have SSI. In a safety determination request form, you have to make the argument that clients' needs exceed the services available in Choices Group 3. The fact that the client would not get any services because they don't draw SSI is not a valid argument. Next slide, please. So when do you request a safety determination form? So TennCare said that you don't appear to be eligible for choices, or if you're worried that you're not going to score a 9, you got a notice back that says you scored less than a 9, or if the applicant requests a safety but the PAE assessor does not agree, the assessor must still complete the safety. A safety can be requested when the application's Acuity score is below a 9, but we have at least one significant deficit. So you can request a safety before the PAE, during the PAE, or after the PAE. Next slide, please. Some of the questions on the safety. Excuse me. These are the questions that are particularly important on the PA, on the safety request form. Goes through the most of the functional measures and asks if not receiving care would result in imminent and serious risk of the applicant's health and safety. So you can read those, but this is where it becomes really important to have documented some of those incidents that we talked about earlier, about a pattern of recent falls or hospitalizations, a pattern of self-neglect, any calls to APS, those can be used as well. So basically you're making the case that this person is not safe if they aren't in the program and receiving care and supervision. Next slide, please. So how do you appeal a PAE denial? Next slide. So the appeals are filed through the long-term services and support, not through the regular appeals unit. You can file the appeal within 30 days of denial. It's received by the long-term services and support team. They have an internal review of the original PAE, and they may request additional documentation. Then they send that to Ascend, who contracts with TennCare to do reviews. And then TennCare reviews the results of the assessment, and then it can go to hearing. Next slide, please. So here are some best practices on appeals. use as much original language as possible from the actual PAE. Doctor's records, caregiver statements have to mention that the need for care existed prior to the date of the PAE denial. If you're arguing that the client should be approved for choices group 2 because their needs exceed services available in group 3, the state has begun to interpret that rule to mean you have to prove that the appellant's needs exceed the $15,000 available in group 3, plus services available through full TennCare, plus services available through Medicare, if they have it, plus non-formal supports. This makes winning a safety determination in court very difficult because the needs have to be beyond all of those services being in place. Sometimes getting a new PAE is a better tactic. Winning a PAE appeal is very hard. Next slide, please. Oh, we've gotten to questions.
Yeah, so I'll help facilitate questions. So please go ahead and use the Q&A box if you have any questions, and I can direct them over to Jill. And Jill, thank you so much for presenting. It's always so helpful to hear more about the process from someone who's kind of who is on the inside and can kind of gives an insight on as to how the process goes. As we're waiting for folks to ask some questions, I do want to highlight some of the things that Jill mentioned that our organization kind of looks at in terms of systemic issues. So one of those things is the kind of SSI limitation for folks who are eligible for choices group 3. We see a lot of folks kind of get to that level of need. So they demonstrate, they need that assistance to qualify them for choices group 3, but simply because they don't have SSI, they won't be able to receive those services. So that's something that our organization kind of has been looking at and trying to understand ways that we can advocate for it kind of going back to how it was originally, where folks did not need to have SSI in order to get those services, or in order to be enrolled in choices group 3. And that kind of feeds into the safety determination that Joe was talking about. Unfortunately, assessors don't automatically provide safety determinations. That's something our organization has really been advocating for, because as you saw in King Triton in that example, that is kind of something that can push him over the edge. So has that 8 score, but it's just not going to get him but he doesn't have SSI. So it's not going to get him to choices group 2 or choices group 1. So just a reminder, 1, you get care in the nursing home. 2, you get care at home. And so if Ariel did not request that safety determination, he's kind of in a pickle there, but the safety determination can kind of push him over. So that's something that we're definitely advocating for. And, the PAE denial appeal process has been something that has been an issue for many of our clients. And we do tend to advise, you may want to just go ahead and submit a new PAE. That might even be quicker to get the services in the home right away, especially if something kind of happened in between that process. So you did your PAE, all of a sudden you experienced another fall. So maybe just getting in a new PAE is just going to get you in the program a lot quicker. All right, so we do have some questions. One is, so Jill, can you explain the relationship between choices and SSI? I know you are discussing it now, but I am still confused. Do you have to have SSI to qualify for choices, or does it just help a lot?
So you have to have SSI in order to qualify for choices group 3 only. Because group 3 is considered at risk an at-risk group for needing higher level of services. And that's the only group that you have to have SSI for. You do not have to have SSI for group 1 or group 2.
Great. And then the second question we have here. Oh, and then I guess just to affirm, yes, you do not need SSI for choices group 1 or 2. You do kind of in the TennCare Medicaid program, you kind of see a lot of relationships with Social Security. A lot of the times, you know, for TennCare eligibility, having SSI is the ticket for someone to get TennCare Medicaid. So it's very confusing, and definitely Tennessee Justice Center is here to kind of help you navigate that, maybe explain some things. And if you want to kind of be proactive, Elder Law of East Tennessee is there to help as well. So next question, to my knowledge, orientation and behavior will only be taken into account if someone has dementia or Alzheimer's. Is that something they take into account even with someone that does not have dementia?
Not to my knowledge. It's considered, if someone has an inpatient behavioral health stay, that those, if they're having functional issues, because like in the example of depression, if they're not eating or taking care of themselves because of depression, that wouldn't qualify them necessarily for the Choices program. Does that answer the question?
Yeah, I think so. Jessica, please feel free to follow up if you need some more clarification. But yeah, the way that I kind of look at it is the way Joel has explained. It's kind of does the kind of behavioral orientation, things like that, does that stem from a mental health disorder, or does it stem from a condition that is caused by aging or a physical disability? Because that seems to be the way that TennCare distinguishes it. Not that we necessarily agree with that, but that is kind of the way that we see it impacting our clients.
And I will add, it is also possible that a person has dementia and depression. And so the task becomes documenting what's going on specific to the dementia. And I know that's very hard to tease apart sometimes, but you know, if you can get some documentation from the doctor to support what you're saying the deficits are related to dementia, then that could be helpful.
I could not have said it better myself. I forgot to turn my video on. I'm so sorry, folks. You're just speaking into the void here. So our next question, what if you qualified for SSI but do not receive a check, only secondary insurance? And I'm thinking that means you receive Medicaid as a secondary insurance.
So
yes.
Yeah, you have to have the medical need to be in the Choices program. So if you have TennCare already, you know, that's your secondary insurance. So some people who have TennCare also have Choices, but not all people who have TennCare need Choices. So the Choices program is a program within TennCare, and so if you have SSI, it doesn't necessarily mean that you need to have the Choices program, but you could. So you would qualify for Group 3 if you do have SSI, and you have the functional deficits that show the need for that.
So the next question is, I've had experience with assessors only doing phone interviews and not doing in-person assessments, and then denied the client choices. Is that normal?
Yes, during the pandemic, the assessors have been needing to do things via telephone interview. So that makes it really important for you, whoever's being assessed and their caregiver, to have as much information as possible about the the struggles and with the functional measures. So it's I think they were planning to go back now that there's been an increase in COVID cases due to the Delta variant. I'm not sure when the assessors are going to get back into the field. And it may be possible to ask for a Zoom or a FaceTime call so that that person can see the environment, or you have to do a very good job of describing what is happening in terms of the functional measures and how the client is not able to do the activities that they need to take care of themselves.
All right, so this is the last question I see, but I think we do have time for a few more questions if anyone wants to add. If they are showing signs of dementia, such as memory loss and forgetfulness, but have not been diagnosed with dementia or maybe Alzheimer's, but are starting to lose motor skills and have cognitive issues, but have no doctor documentation, what can they do to get help through a program such as Choices?
My recommendation would be to ask for a referral to a neurologist and talk to the neurologist about what you're seeing, and make sure that gets documented early on. It is important to have a diagnosis, and so even if you go to your primary care physician and say, these are some things I'm noticing with my mother, my father, whoever, and ask them for a referral to a neurologist so that there can be a formal evaluation. There will be a battery of tests given, and then a diagnosis can be given, because it doesn't just have to be it doesn't only have to be a dementia diagnosis. It could also be another neurological issue, Parkinson's or some other movement disorder, MS, whatever the thing is. It's important to get started as soon as you start to notice symptoms, because some of so Elder Law of East Tennessee is located in Knoxville, and some of the neurologists that specifically do these types of tests have a very long waiting list of months long. So get started as soon as you notice symptoms, get that process started. And I will also say that most of the neurologists that we work with require a referral from the primary care physician. So that's where you should start. Go to the primary care physician, talk about what you're seeing, ask for a referral to a neurologist for a more formal evaluation process.
Great. So I don't see any questions anymore. So I'm just going to close out with our slide, but if anyone has another question to sneak in, please feel free. So just to kind of reiterate, I'm from the Tennessee Justice Center. I'm a staff attorney there. I provided some of our contact information. If you or a loved one or someone you know is having some issues kind of navigating the program, or kind of has experienced denial and needs to kind of touch base to understand next steps, our organization is definitely here to help. If you have a story to share, we do a lot of advocacy work around independence. And so if you kind of are a partner organization like Elder Law of East Tennessee, you can definitely reach out and we can, brainstorm things to bring to the state's attention. And I don't know if you want to talk a little bit about elder law of East Tennessee, Jill.
Will you say that again? I'm sorry. I was looking at the chat.
Oh, yeah. Oh, I do see that we have some coming in. Let me check that out. Here's a question. I work in independent living and I have seen residents who can cook, feed themselves, bathe, walk, and are cognitively sound who were approved for choices in the home. On the other hand, I have residents who have advanced dementia and are at risk for malnourishment, safety concerns, and isolation who were denied because they did not have SSI. Can you help me make sense of this?
It seems like a variation in how the assessors evaluate on one hand, but in the functional measures, it seems like they might qualify for group 2, not group 3. So in that case, it might have been helpful to appeal or to reapply. And there is no limit to the number of times you can apply for the choices program. So if you're denied or if you get into a different group than what you were hoping for, you can reapply. And so basically I would say it depends on this, the difference here could be the difference in how someone advocated for them, really. So, you know, I know that doesn't make sense, but that's the reality of, you know, of what happens when you have humans involved. You know, we are flawed and we see things differently sometimes. So I wish I had a better answer for you, but that really is what it can boil down to sometimes.
Yeah, I think that's a perfect way of explaining kind of some of the tools in folks' toolkit to try and, you know, push the process forward in a positive way for the applicant. Unfortunately, this is just a policy choice that Tennessee made regarding choices group 3. But if you do see someone kind of with all those deficits that you mentioned, I think Joe's right, choices group 2 or 1, if the person is interested in kind of a nursing home placement, to just have an advocate on their side, just provide some of that medical documentation, because the assessor is a person, just a human. And so they might, as Jill says, see something differently, or maybe they just came on a good day for that applicant. And they don't, that day was not like a typical day for that person. All right, here's another question. This is to clarify question before. This is regarding the dementia or orientation. So outside of dementia, so if the person, I guess, does not have a dementia diagnosis, do they get behavioral orientation counted towards their score? The person asking understands that depression or mental health disorders do not count, but can you give an example of what other behavior orientations would count for choices? Would, like you said, MS count?
Well, it would count if the person is having some of those behaviors that you might see in someone who has dementia or Alzheimer's. So what you try not to get hung up on the diagnosis. Let's focus really on what's the manifestation of the behavior. So if someone is wandering or if they're acting unsafely, you know, wandering out into the street, even sometimes we can make a case for allowing strangers to come in to their home who are, you know, selling something or who knows what. if that discernment is gone for their own safety, that's the question, is how are they meeting the functional measures? And so try not to get caught up in the diagnosis too much. It's important to have one, but if you can show and your doctor's records indicate that there are behaviors, that's really the most important piece, I think.
Great. So the next question, if the applicant gets onto choices group 1 or group 2, but we're hoping to get into group 3, can they appeal to get onto group 3? Will they still be allowed to be on choices group 1 or 2 while they go through that appeal process?
My recommendation would be to just stay on group 1 or group 2, because so you get a certain amount of services per year, and I can't remember right now what group 2 is. I don't have that figure in front of me. It's increased. They increase it a little bit every so often. So I'm going to say it's more in the range of 70,000 a year, whereas group 3 is 15,000 a year. So you can be in group 2, and let's just say you only need help a couple of days a week, which is what group 3, $15,000 a year would get you. So I would say stay in group 2 and just, use what services you need, because as your disease process progresses, you're going to need more and more care. And so then if you're in group 3, you're going to have to, apply to get into group 2 or group 1. So this will just save you some time and aggravation down the road, really. And if you're approved for group 1, but so I'm going to go through the groups again, just briefly. Group 1 is that you meet nursing home level of care and you receive care in a nursing home. Group 2 is you meet nursing home level of care, but you're receiving care in the community. Group 3 is you're in an at-risk group, and so you're getting care in the community as well. So if you get approved for group 1, that means that you are in a nursing home or you are headed to a nursing home for care. So if you get approved for that and you want to be in the community, which is what you would, if you were in group 3, that's where you would be. I would say go through with the enrollment process, get established and enrolled in the Choices program. And when the care coordinator from your MCO comes to you and says, I'm your care coordinator, you're now enrolled in the Choices program, say to them, thank you, I would like to transition back to the community. And that way you can keep the Choices program and go back into the community. Because if you leave the nursing home without going through that transition process, you will be disenrolled from Choices, and then you have to start all over again with the process out in the community. So take advantage of being approved for group 1, work with your care coordinator, and they will help you get a safe transition back to your home or to an assisted living, whatever would work out in your case.
I could not have said that better myself. That was an excellent explanation. So I don't see any other questions. Maybe Jill, you can close out with some of the things Elder Law of East Tennessee does, and maybe why folks should reach out to your firm, and then we can close out if I don't see any other questions before 12.
Sure. Thank you. So At Elder Law of East Tennessee, we help folks with life care planning. And one of the things that makes us different from other law firms is that we have elder care coordinators, which is what I am. And so we have a social worker, nurse, and a gerontologist who work as elder care coordinators. And our role is to, advocate for folks who need public benefits but haven't been able to get them. And so we are with you every step of the way. When we determine that what you need is to be in the Choices program, we arrange for the assessment. We are on the phone with the assessor while you're doing your assessment. And so we kind of hold your hand through the process. And if that's not where you are yet, not everybody who comes to us needs TennCare or the Choices program, but we do in general assessments of our own, of your living situation and your support system, and we try to make recommendations on how to help you age in place as long as you want to and need to. So that's kind of what we do. It's a little bit of a step up from just basic estate planning. You can get that from any attorney. So we have a little bit more of a specialty, I think.
Yes. Someone even asked if there's an elder law in Middle Tennessee, an elder law of Middle Tennessee.
There is an elder law. There are several elder law attorneys. So what you want to do if you're looking for an elder law attorney is to look for a firm that has a certified elder law attorney, because those folks have taken an extra exam to become certified, and they are quite familiar with Medicaid rules and some federal laws that affect Medicaid and how that can affect your estate planning. So yes, there is Takis McGinnis Elder Law I think it's in Hendersonville. That's one that pops up for me. I'm sure there are others. I don't know, Vanessa, if you guys have a list of those in Middle Tennessee.
Yeah, we do. We are aware of some elder law attorneys specifically because a lot of our clients kind of need that extra level of legal support. So you can reach out to our organization if you are unable to kind of find on your own somebody. And also, that one thing to know is the Legal Aid Society does assist with choices appeals, specifically, I think, for financial, but that's the caveat for that is the family needs to be below a certain income for them to work with folks. But yeah, so Legal Aid Society is an organization you should keep in mind if you're struggling to find some, proactive legal help through an elder law attorney. So the last thing was, is this session recorded and can I access it later? I believe it is definitely recorded, and I think we're going to send it out. We're definitely sending out our slides, but I don't know, Nicole, if you want to.
Yeah, we're going to go ahead and put it on YouTube, and we'll send it all to you tomorrow.
All right. Well, I think that's it, and we've reached our time. So thank you so much, everyone, for joining us. And hopefully this webinar clarified some things for you. And please keep in mind, if you're looking to work proactively and set things up for your loved one, reach out to Elder Law of East Tennessee. If you're struggling to kind of navigate or having some issues, please reach out to our organization, Tennessee Justice Center. All right. Well, I hope everyone has a good rest of your week. And thank you so much for joining us.